So we're going to start off the session with Dr. Dustin Yates from the University of Nebraska-Lincoln. He's going to be presenting a talk on metabolic fetal programming related to maternal stress, placental insufficiency, and intrauterine growth restrictions. So Dr. Yates, the floor is yours.
All right, thank you for that introduction, and thank you for the invitation to come visit with you today. I always appreciate the opportunity to talk about our research, and if those opportunities happen to present at a beachside hotel, that's even better. So I'm going to talk about a couple of our recent studies that we've done in this area of fetal programming of metabolic function, and specifically how chronic exposure to stress in utero changes that fetal programming, and ultimately how those changes underlie the growth and the metabolic dysfunction that we know is associated with this IUGR, intrauterine growth restriction phenotype, or low birth weight, if you prefer. So I always like to start with this slide, because I'm the kind of person that likes to force pictures of my children onto others, but also I think it's a really good reminder that fetal programming is a normal and natural and necessary thing that happens in every organism, every individual. It's really simply a description of the various developmental processes that take you from nondescript clump of cells, quite literally, to the humanoid figure, or cow or sheep or whatever type of mammal you happen to be. We know that in non-litter-bearing species, about 90% of these developmental milestones are reached prior to birth. And so maybe the most simplistic and straightforward example I can give you is think about how many fingers and toes you develop before you're born versus how many you develop after you're born. They're all before birth, and then after birth, it's more about growth and way less about development. And of course, it's not just about fingers and toes. It's also about all these various mechanisms and processes that contribute to your ultimate metabolic function, and then also growth capacity. And that's all well and good until something happens in utero that pushes that fetal programming kind of off course. And we know for a fact that stress can do this, especially chronic stress. So the most common cause of fetal stress is placental insufficiency. And what that does is it robs the fetus of oxygen, of glucose, amino acids, all of these things. And so the fetus has to adapt its development in a way that makes it thrifty. This is, of course, the classical thrifty phenotype hypothesis that Hales and Barker struggled to get published in the early 90s, and now has changed the way we think about pretty much every aspect of life sciences. We know that this adaptation absolutely helps the fetus survive these poor conditions. The problem is, just like fingers and toes, once these individuals are born, you got what you got. And that becomes problematic when they're born and suddenly they're not hypoxic, suddenly they're not hypoglycemic in most cases, but their metabolic programming reflects that. And so that these adaptations that were helpful in surviving the fetal conditions now become a liability after birth. And we know this from bukus of epidemiological studies performed in humans. We know that individuals that are born with low birth weight due to intrauterine growth restriction are actually about 18 times as likely to develop things like obesity, type 2 diabetes, hypertension, hyperlipidemia, all of these metabolic disorders later in life. Those very same adaptations that occur in our food animals cause them to exhibit really poor feed conversion because they're metabolically inefficient. They're being thrifty when they don't need to be. And then the growth potential that's reduced causes poor carcass yield and poor carcass merit. So they're more expensive to feed because they're being inefficient, and then at harvest, they're worth less money. And so, of course, that's problematic. Despite the overwhelming evidence for the link between fetal stress and intrauterine growth restriction, and then these postnatal deficits in growth and metabolic function, there's really a lacking in our understanding of the mechanisms that cause that. And so that's kind of where we decided to set up shop. We decided that our long-term research goals of our lab is going to be to understand what those adaptive processes are from a mechanistic perspective, which is actually pretty ambitious because I'm not a trained molecular biologist by any means, but we figured that's probably where we need to know. And then more importantly, once we do understand those, we need to figure out how best to treat them so that we can improve the outcomes of low birth weight or IUGR. So to do this, we use this animal model that is the pregnant sheep. And we have written reviews lauding the importance and the value of this. A lot of other people have as well. The importance and the value in this sheep is that it tends to tolerate placental and fetal manipulation better than most any other mammalian species. And the reasons for that are kind of what Erin explained in her talk yesterday. It has a more dynamic and a more robust endocrine support of that pregnancy. And so it's much more tolerant. I know Larry Reynolds tried to do some of this work in cattle, and it wound up costing him a fortune because he was just losing tons of animals due to abortion. And so he pretty quickly switched to the sheep model as well. Erin also talked about understanding the differences among species. We believe that if you do understand those and you acknowledge those differences, then the information that you produce in a sheep can at times be very valuable, very applicable to the much more expensive livestock, but then also really all mammals, and that includes humans. So I want to start by just going back kind of over the last 8 years, really all the way back to my time as a postdoc at Arizona, and talk about 3 kind of generalized findings that have been produced in this model that'll help me kind of set up the studies that I want to talk about today. And you'll notice that our lab is very skeletal muscle centric. That's kind of our niche. There's other labs studying cardiac function and pancreatic function and liver function and all that. That's kind of over our head. So we focus on the skeletal muscle mainly because of its importance in glucose homeostasis. And so the first thing that we know is that skeletal muscle growth capacity, growth potential is reduced. Now that's not a novel finding with our lab, but we were able to extend that by showing that a big reason that the capacity is reduced is because the myoblasts, the stem cells for skeletal muscle, have an intrinsic dysfunction. We know this because when we isolate them from the in vivo environment and we put them in culture that basically represents like a Garden of Eden for these cells, they still underperform relative to the stem cells that are taken from uncompromised fetuses or neonates. The second thing we've come to realize is that skeletal muscle specific glucose metabolism is impaired, and specifically glucose oxidation. That'll be a lot of the data I show you today. This basically springboarded off of 2 of what really are, I guess, my 2 favorite papers of all time, favorite studies of all time, both from the University of Colorado Medical Center that showed that the IUGR fetus has reduced whole body, so the whole fetus glucose oxidation rates. And we were able to extend that by showing 2 things really. One, that it is skeletal muscle centric. And then we were also able to show that those deficits persist into the offspring. So they are indeed programmed. They're not just a product of the poor intrauterine conditions themselves. They also seem to be related to what we know is impaired insulin sensitivity. I still put this bullet point in my talks But I'll be honest, with every study that we do, I feel like I understand this less and less. Listening to the debate yesterday about insulin resistance in the milk cows, coming from like across the room, and I was just thinking, I have that same debate like in between my ears all the time. And so maybe the best way to describe it is selective insulin resistance, because there's some functions of insulin signaling that are actually even increased in these animals. And then the third thing here is really our first insight into what the actual mechanism might be. And this is a programmed alteration of adrenergic tone. And we know that adrenaline is obviously a stress hormone, but the adrenergic system, particularly the beta adrenergic system, is a very important regulator of skeletal muscle growth and skeletal muscle glucose metabolism. And so we have this beta-2 receptor that represents about 90% of the beta receptors in most skeletal muscle. That can change among species, it can change among muscle groups, but the ones we study, it's about 90%. It's also stimulatory for growth and glucose metabolism. And it's also reduced, and we have a couple of different models here, a couple of different stages of life, and then we have both skeletal muscle proper and the myoblasts, the stem cells. And over and over and over, we see this same pattern, that this stimulatory beta-2 is reduced in expression, whereas beta-1, which makes up the bulk of the remaining 10%, it tends to be inhibitory, can be inhibitory for growth. It's certainly inhibitory for glucose metabolism, and it's either not changed or in some cases even increased. So we have the good guy that's being reduced in expression and the bad guy that's either standing pat or being increased. So we have this relative shift from stimulatory to more inhibitory beta adrenergic tone. We know from this infusion model that this arises due to the chronic fetal hypercatecholaminemia, which is a word that took me about 2 months to learn to say and about 2 years to learn to spell. But it's a chronic increase in the circulating catecholamines in that fetus, and they're of fetal origin. And then we know from work that way predates me, in fact, some of it even before I was born, that it's this chronic fetal hypoxia that arises from the placental insufficiency that drives the elevation of those fetal catecholamines. So in our simplistic way of thinking, we thought, well, if we can somehow eliminate the fetal hypoxia, then we eliminate all the progressive steps after that. We eliminate the rise in catecholamines, the adrenergic adaptations that come from that, and then, of course, ultimately, the pathologies we see. And so that's what we attempted to do. And this is a study, this is my first grad student, Caitlin Cadaray. She was my first master's student, and then she stayed on and became my first PhD student as well. Now she's at Colorado State on the faculty there. This is her MS project where we attempted to deliver intermittent maternal fetal oxygen supplementation to reverse the hypoxia that we know exists in that fetus. So we produced this model, and this is the gold standard model of IUGR in the sheep. You take a pregnant sheep and you expose her to chronic heat stress about 50 days, right in the middle of gestation. And why that period? Well, that overlaps with peak placental development. And so we're stunning the placenta. They get hyperthermic, redirect blood flow to the periphery, away from the gravid uterus. Placental development suffers because of that. It's not stunning the fetus yet, but we take those animals out of the heat chamber, let them continue to gestate, and ultimately the fetus outgrows that stunted placenta, and that's when it starts getting hypoxic, hypoglycemic, all of those things, and of course, that's when we start to see the growth restriction. And this is a progressive thing. So the hypoxia gets worse as the fetus tries to keep growing and continues to exceed the oxygen level that stunted placenta can deliver. And so we know that they're basically hypoxic pretty much the entire third trimester, but it's the worst in those 2 weeks leading up to term. And so that's what we targeted. So we did a second group of IUGR animals. And in these, we actually did the tracheal catheterization in all the animals. But this second group, we infused 100% oxygen for 8 hours a day, every day for the last 2 weeks of gestation. And so that gave us these 3 groups. We have thermoneutral ewes carrying control fetuses. We have heat-stressed ewes carrying IUGR fetuses, and then we have a second group of ewes carrying IUGR fetuses that got maternal insufflation of oxygen over the last 2 weeks of pregnancy. All these ewes were allowed to lamb out. We weaned these lambs at birth and then hand-reared them. Grad students hand-reared them to 30 days of age. And so we call that our neonatal age, the 30-day period. And what we found was we were actually able to recover growth, both prenatal and postnatal. And believe me, nobody was more surprised than me at this finding. But you see the bottom line there, the solid black squares, that's the IUGR group. You see they're smaller at birth, and they continue to be smaller all the way through this 30-day period. Whereas the would-be IUGR group that got that prenatal oxygen supplementation, they look a lot more like the controls than they do the IUGR group. Teresa pointed out yesterday that body composition is every bit as important as actual just linear growth. Agreed totally. Here's some kind of rudimentary estimations of body composition. So we have these structural measurements like body length and crown circumference and cannon bone length, and then you divide that by body weight, and it kind of gives you a metric of how skinny the lamb is. And so in this case, a bigger number would be worse. And you see that at birth, especially, these IUGR lambs are not only smaller, but they're asymmetric in body composition. And they stay that way. It gets a little better as they advance towards that 30-day period. But the IUGR lambs that had received the prenatal oxygen, again, look much more like the controls than they do the IUGR group. Okay, so what about glucose? So to measure in vivo glucose, we do this what we call a Hindlimb prep, where we catheterize the the femoral artery and vein on one leg. And so when you draw simultaneous blood samples, you get the difference between what's in the blood coming into the Hindlimb and what's leaving. And so that difference represents what, for example, the difference in glucose represents how much glucose was taken up through one pass through the Hindlimb. We put a blood flow probe in the other leg to estimate blood flow in this leg, and that allows us to express that as a rate. And then we put an infusion line in the other Hindlimb, and what that does, so for example, we can measure endogenous glucose differences or lactate or whatever, oxygen, whatever, but then we can also infuse in a little bit of radioactive glucose and measure radioactive carbon dioxide produced, and that allows us to estimate glucose oxidation rates. We do all of that stuff under resting conditions, and then we do it again under hyperinsulinemic, euglycemic clamp conditions. And so the difference between those two would be insulin-stimulated glucose metabolism. And what we see there, and this will kind of be the theme throughout here, is that glucose, I still don't know. 8 years in, I still don't know whether it's actually glucose utilization or uptake. I still get confused as to which term to use. But regardless, glucose clearance by the hindlimb tissues is down just a little bit in those IUGR-born neonates, but it's completely recovered in the IUGR neonates that had received prenatal oxygenation. In fact, it's even better than the controls we see here. The same story for the glucose oxidation rates. We see a massive loss, and in fact, here we even see a loss at basal conditions in glucose oxidation rates that are completely recovered by that prenatal oxygen delivery. So we know the hind limb is only about 60% skeletal muscle. So to kind of back this up, we harvest the FDS, flexor digitorum superficialis. That's another word I had to practice. This is a hind limb muscle. We can get it tendon to tendon and then strip it longitudinally. So we have these intact muscle strips, and then we can kind of perform a similar study in culture where we can measure glucose uptake rates, which you see here. This is insulin stimulated. Glucose uptake is not different, but we do see the same deficit in glucose oxidation in those IUGR-born neonates, but that's it's not fully recovered, but it's certainly improved in the IUGR neonates that had received prenatal oxygenation. Okay, good stuff. Here's what it didn't do. It did not improve, Teresa described this beautifully, how phosphorylation of AKT is a good proxy for insulin sensitivity, insulin signaling. We expected there to be a deficit in that. We did not recover one bit of that deficit with our prenatal oxygenation. And then the real kicker here is the content. This is protein content for beta-2 adrenergic receptor. We knew it was going to be down based off of everything we've seen for 8 years. And this is semitendinosus muscle, by the way. We knew it was going to be down, but we did not recover any of it. So we recovered the phenotype, but we didn't recover the mechanism that we thought we were after. Okay, that'll make you think, right? And so we decided, well, the problem was we weren't being direct enough. And so treating with oxygen, that's an indirect way of treating the adrenergic changes, right? And so we decided we needed to be more direct. And so this was the PhD work of Rachel Gibbs, maybe the best grad student I've ever seen, not had, but seen. And she was able to do a similar study where we produced these IUGR lambs, but for our rescue group, instead of treating them prenatally with oxygen, we treated them postnatally with clenbuterol. Clenbuterol is a potent, powerful beta-2 agonist. So we know beta-2 expression is down, so we're going to try to compensate that by providing more of the ligand here. And then one other caveat, we took them out to 60 days of age, which we call our juvenile stage. I'm really glad we did this for this study. We'll never do it again. 60 days is a long time to hand rear 31 lambs. We saw a lot of the same stuff in growth. Even at this later stage, the IUGR-born juveniles were still smaller, and you see that in their birth weight there. But as you would expect, the clenbuterol recovered that. We know that because beta agonists are used to improve growth in animals all the time, right? So no surprise there, and of course that's reflected in their average daily gain as well. As far as body composition, we actually got this really cool tool, this BIA machine, bioelectrical impedance analysis. If you don't have one, I recommend you get one. They're really cool. Or even better yet, you can do what I did and find somebody that has one and just borrow theirs. But what it does is it estimates body composition in the live animal. Really powerful thing to be able to do. And in that top square, we have, those are the estimations of muscle weight. So the sum is all the muscle in the body. That's the loin, sirloin, leg, rack, strip, I think, and then the loin, sirloin, and leg. It doesn't matter. Basically, throughout this, it's saying that muscle mass is reduced in those IUGR-born juveniles, and it's recovered by the clenbuterol treatment. And then at necropsy, when we actually measured loin eye area, it showed the same story. Reduced in the IUGR-born lambs, but recovered when we treated them with clenbuterol. Now, this other side here, I think it was Virginia, you asked this question of Teresa in the preemies. You said, why are they not fatter? All this physiology, it seems like they should be fatter. Why are they not fatter? We see the exact same thing in the IUGR fetus and neonate. Seems like they should be fatter, but they're not. But if you take them out to the juvenile stage, you see right there, they finally start to be fatter. So maybe it just takes that long for them to catch up and to deposit enough that it actually shows up in a BIA estimation. And so you see at 30 days, they're not fatter. That's the estimated fat to protein ratio there. But at 60 days, the fat ratio is up relative to protein, and then of course it necropsy, so that's basically like the skinned animal. And then when we measured it by when we had it sent off to be measured by proximate analysis, and that's the loin muscle there, it showed the same thing. The fat content was up in the IUGR born lambs relative to protein content, but that was rescued by the Clenbuterol treatment. Same story once again with the metabolism, glucose uptake. I called it uptake this time. Uptake is it was increased by the Clenbuterol, and it's always a little bit concerning when you improve something that wasn't a deficit in the first place. And so maybe that's just a titration thing. I don't know. We'll try to fix that on the next study. But certainly the glucose oxidation rates showed the same story. They were massively deficient, and the IUGR born juveniles recovered by the Clenbuterol treatment. And in fact, there was even a tendency for that same pattern in basal conditions. What did Clenbuterol not do? Well, it didn't recover ex vivo skeletal muscle glucose oxidation. You see that that group is not different from the IUGR group that wasn't getting the Clenbuterol. So what does that tell us? It tells us that once you remove the muscle from that in vivo condition that has the Clenbuterol in it, you're basically removing it from Clenbuterol exposure, and you're losing your effect. And so I guess what that's telling us is that we're only treating the fetal adaptations. We're not correcting them, which is still good. I mean, it's nice to have a way to treat them if they occur, but we were not fixing the problem ultimately. And so both of these studies together, the oxygen study and the Clenbuterol study, show us that although obviously that beta-2 deficit is involved, it's not the whole story. It's clearly not the full mechanism. So we're left looking for another mechanism, and we just happened to be performing a study that had nothing to do with fetal programming. This is just a traditional heat stress study in feedlot lambs as a proxy for feedlot cattle. And we heat stressed them for 30 days. And what we noticed was that after a while, they really start exhibiting this phenotype that looks a lot like what we see in our IUGR fetuses and neonates. Now, it's not a programming effect. They're just responding to the heat stress, but it's very obvious that they're kind of presenting the same outcomes. Something else they're presenting, and we think this kind of explains that, is after a while they become inflamed. They develop chronic systemic inflammation. And I apologize, I know you probably can't read that. The top graph there is epinephrine, so we know that's going to be up because they're heat stressed. The one with the red arrow pointed to it is circulating TNF alpha. And after about 14 days of heat stress, it becomes increased, and it stayed increased through the 30 days. You know, we terminated the study at 30 days, but it was still increased at that. So they are inflamed. What they're not exhibiting is any increase in cortisol, and maybe because they were being pair-fed to the controls, and then insulin's also not different. And on this side, we have total and differential white blood cells, which also are increased in circulation of the heat-stressed animals, particularly monocytes, which are big-time producers of inflammatory cytokines. So we thought, well, maybe that's the mechanism in the IUGR fetuses. And so we went after that, and this is Caitlin's dissertation study here. So we changed up our model a little bit. Instead of using heat stress to produce placental insufficiency, we waited until the 3rd trimester, and then we started injecting the ewe serially every 3rd day with LPS to induce maternal fetal inflammation. We did that through, I know this says day 15, that's how long we monitored it, but they got their last LPS injection on day 112 of gestation. And then we studied those fetuses about 2 weeks after the last LPS injection. And so we have these 2 groups, the saline injected ewes carrying control fetuses, and then the LPS injected ewes carrying the maternal fetal inflammation induced IUGR fetuses. And again, we studied them about 2 weeks after the final LPS injection. And I think, Joe, you were talking about, I think it was you that said, it's very difficult to to measure in vivo glucose fluxes across the hindlimb. It's not hard. You just anesthetize the U and do a midline incision and expose the uterus and cut through that and bring, the fetus halfway out, and then catheterize the femoral artery and vein and put it all back together, and then, bring those catheters out the uterus and out the body wall under the skin, and then, put them in a nice little pouch on the side. I mean, I can show you over lunch if you want to know how to do that. So what we saw is that first off, these fetuses were inflamed. So we originally started calling this maternal inflammation, and after we saw this, we changed it to maternal fetal inflammation. And again, this is 2 weeks after the last LPS injection. And you see that at day 120, the top graph there, maternal inflammation, the TNF alpha is still up, but by day 125, it's really starting to subside. Not so in the fetus. The fetus has higher circulating TNF alpha at day 120, and it's every bit as high at day 125, a full 2 weeks after the last LPS injection. And then it's reflected in the circulating white blood cells here too, everything except lymphocytes, which I have no idea why they weren't elevated, but certainly the monocytes were. A little bit of residual increase in the maternal white blood cells as well. They were also growth restricted. And so you see this is at necropsy at day 125. We'll say that growth restriction was less severe than the heat stress model, and the asymmetry in body composition that was produced was also less severe, but it was present. And then here's the big one, the glucose metabolism. And we see that the top graph, once again, glucose uptake by the hind limb, or what did I call it this time? Utilization. Glucose uptake, utilization, whatever, was not affected. But once again, we see this massive deficit in insulin-stimulated glucose oxidation by the hind limb tissues. And then that was backed up by the ex vivo skeletal muscle as well. A massive reduction in insulin-stimulated glucose oxidation. And we also see that our proxy for insulin signaling, the phosphorylation of AKT, was reduced as well. And it didn't matter whether they had a little bit of insulin in culture or a lot, it was reduced. Okay, so our conclusion from that is that fetal inflammation does indeed result in this IUGR phenotype, but that's only part of it, because what we really needed to know is, does that persist in the offspring? To be blunt, if it didn't, we probably wouldn't care much about it, because that would mean it's not programmed, which would mean it's not a target. It's not a postnatal target for us. And so we basically decided to do the same study, except instead of studying them at the fetal stage, we studied them at that neonatal stage. And this is Robert Poissant's master's project, and then he went on, and now he's doing a PhD at the Smithsonian Institute in red pandas. So we have these same two groups, the control, the saline injected controls, and then the LPS injected IUGR lambs, but instead of studying them at the fetal stage, again, these were allowed to lamb out, and we studied them at 30 days of age. And this is a really busy slide that, if you know Robert, that fits perfectly. So I'd put up the red arrows to just draw your attention to the fact that they were smaller at birth. They continued to be smaller at 30 days of age. And of course, that's reflected in their growth rates, their average daily gain. And just like in the fetus, glucose oxidation rates were impaired. And so we see that the uptake rates were not affected, but the insulin stimulated, and in this case, even the basal glucose oxidation rates were impaired. That was reflected also in the ex vivo skeletal muscle, and we had a tendency for a reduction in insulin-stimulated phosphorylation of AKT. These animals also had high circulating plasma triglycerides, which I failed to mention, but that's true to a lesser extent in the heat stress model. So we have this phenotype that we expected based off of inflammation, and now we have increased triglycerides, which we know are pro-inflammatory. And so there's like no way these animals don't express increased inflammation, right? Well, not so much. In fact, when I saw this data for the first time, happened to be about the time where this bald spot started forming. So not only do they not have increased TNF alpha, they have 50% less circulating TNF alpha than the controls, and really inconsistent and kind of meaningless changes in the circulating white blood cells. So I panicked over this for a few days, and then it hit me like a ton of bricks. What are we supposed to do when we get data that's opposite of what we expect? We call it compensation, right? It's a compensatory mechanism. And so we know that endocrinology is a ligand, but it's a receptor for that ligand, and then all the signaling that happens after that. And so what if that signaling is so enhanced that the ligand is being reduced as compensation? And in fact, fortunately, that was the case. And so this is the TNF alpha receptor protein content for TNF-R1 in the semitendinosus muscle. And I don't know what happened to my p-value there, but it is statistically increased in those lambs. This is not a particularly robust evidence, but then I had a geneticist friend introduce me to the world of RNA-seq, right? And how about that? That tells the story in any way that you would want to see it. And so on the right there, we have the IUGR fetus, and this is all semitendinosus muscle. And then on the left, we have the neonate. And we see that every step just about of the TNF alpha signaling pathway in the semitendinosus muscle of that IUGR fetus is enhanced all the way down to the steps that we know impair glucose oxidation and impair myoblast function and muscle growth. And it's even better in the neonate, because now we start adding other cytokines in addition to TNF alpha. We see that compensatory reduction just like we do in the circulating TNF alpha, but everything from the receptor down indicates that those inflammatory pathways are enhanced all the way down to the deficits that we've been seeing for years. So our overall conclusion for this is that indeed enhanced inflammation seems to be another mechanism that, in addition to the adrenergic changes, ultimately result in this phenotype, growth and metabolic pathologies. But just like with the adrenergic side of things, we know this isn't the only mechanism. In fact, there's still work to be done there, which is job security. Just real briefly, the next steps we've already started is to treat that, right? So we're treating the fetus, the IUGR fetus, by infusing everybody's favorite anti-inflammatory nutraceutical, which is the omega-3 fatty acids. And our early returns on that show that we're actually are being able to reduce the circulating white blood cells, including the monocytes, and then we're actually recovering some fetal growth, and then also the muscle-specific growth in those fetuses as well. This is a proceedings paper, Megan. Is she still here? All right, you tell her, Glenn. All right, so that's what I have for you. Thank you very much, and I'll take any questions you might have.